been having real problems with Panopto lately, so hopefully this records okay and everything's clear, because that would not be a good thing to not have. Again, this is Einthoven's triangle, which is just looking at your three primary limb leads. Lead 1 from right shoulder to left shoulder, lead 2 from right shoulder to left foot, and then the following lead 3 completing the triangle. In the coronary care unit, or the medical ICU, whatever it's called nowadays, where we have patients who are post-MI, these two alternate leads are ones that are utilized. And they're called modified chest leads because they mimic a chest lead, the V leads, if you will, specifically V1 and V6. MCL1, because of its placement, looks at the ventricular septum, and MCL6 looks at the lower lateral wall of the left ventricle. MCL1 is used quite often to distinguish between this sounds like a goofy thing, but a right and a left PVC. So when you see a PVC occurring, is it occurring in the right ventricle or the left ventricle? You can actually pick that up by looking at the modified chest lead. You can also look at some bundle branch blocks a little bit better with that lead. So just recognize that there's some other leads that can be there on a continuous monitoring basis. So there's our three unipolar leads, which are basically your augmented voltage leads. And the negative pole to this is located in the center of the triangle or the center of the chest, however you want to view it. So remember that a lead is a combination of a positive and a negative electrode, and it's always looking in the direction from negative to positive. So AVR is looking from the center out to the right arm, AVL is from the center out to the leg, and AVL from the center down to the foot. Doesn't really matter which foot, it's straight down. Okay? So those are three augmented voltage leads. And how that negative is derived, you don't want to know, because I would have to kill you. So let's leave it at that. Placement of the chest leads. Going back from Mary's class, as far as doing EKGs, you should know the placement. I would feel comfortable saying which lead is in the fifth intercostal space, mid-clavicular line, and you would have to tell me V4. Old news? Okay. So again, how they're placed is critical for measurement, with 4, 5, and 6 following a straight line in the fifth intercostal space. And they're kind of just giving you that view where the negative pole, again, is in the center of the chest, and the positive pole is going out to each of those individual electrodes. So adding them all up together, your three limb leads, your AVR leads, or your augmented voltage leads, and your 6 chest leads all give you the 12 lead EKG. 6 of them are in the frontal or vertical plane, 6 of them are in a horizontal plane. So they're kind of looking at the heart from a bunch of different angles. Now, there are the possibility, we always have been talking about MI being a left ventricular, but the right coronary artery can have a lesion also that causes reduced blood flow to the right side of the heart, leading to a right MI. And management of a right-sided MI is totally different than management of a left-sided MI, so it helps to distinguish between the two. And the way that we do that is with a right-sided chest lead. And the right chest leads basically are mimic of a left. They're placed exactly the same, but they're just in reverse, if you will. Okay? And what we would do is we would do a standard 12 lead, then change the electrodes to get the right-sided, and mark on the ECG tracing, instead of V1, V2, V3, we would put V1R, V2R, V3R, etc. Okay, so it gives us a right-sided picture. Make sense? Then there's the posterior leads. Now typically, we only look at V7 through V9. If you think about it, the heart is a box where we're not concerned about the top so much, because that's where the atria are, but the ventricular wall has an anterior, a lateral, a septal, an inferior, and a posterior wall. None of the leads look at the posterior wall directly unless you put these posterior leads on. And what ends up happening is we have V4, V5, V6 all in a straight line. We just keep going around the backside along that straight line. So we're in the fifth intercostal space in the mid-axillary posteriorly, basically below the scapula, and just to the right, just to the left of the spine for V9. If you got a good cardiologist, if you got a good ER doc, yeah, because if they suspect the right ventricle, they want to be able to see the posterior wall. The right ventricle and the posterior are fed by that right coronary artery. To some extent, the left circumflex, but yeah.
What are they looking for again on that one?
Posterior wall. Your posterior wall, you don't see anything directly with a standard 12-lead EKG as far as ST changes. Okay. Yeah. I'll come back and talk about that a bit. Okay. So here's the important thing, and put a star by this slide because this is going to be one of the ones that you're going to be referring back to, and there's different pictures of this as we go through it. But by looking at a combination of leads, I can determine if the ST changes, the development of a Q wave, the peaking of a T wave, is occurring in a specific part of the heart. And this is how I can tell if it's an inferior wall infarction versus an anterior wall infarction. Okay? If you look at 2, 3, and AVF, that is showing you the inferior wall. 2 is pointing down, 3 is pointing down, F is pointing down. So it's the inferior wall. Lead 1, right shoulder to left shoulder, just looking across towards the left. AVL, looking towards the left. And V5 and V6 are on the very lateral wall of the chest and also looking at the lateral wall of the left ventricle. V1 and V2 are looking at the septal wall. It's the first two that come off on either side of the sternum. That's going to look at the septum. 3 and 4 is the anterior wall. And again, V7, V9 is what we would pick up on the posterior. You can also see what are called reciprocal changes in V1 through V4 telling us the posterior. Now that's kind of odd, but what would end up happening if I had ST elevation indicating that I had ischemia going on, what I would see in V1 through V4 if I had posterior wall ischemia is I would see ST depression. It's the reverse of what you would think you would see, but that's why they're called reciprocal changes. Okay? So key ones that I want you to pay attention to. 2, 3 in AVF, inferior. 1L, V5, V6, lateral. V1, V2, septal. V3, V4, anterior. V7 through 9, posterior. Okay? Now, I believe in your other course you have this text that I have such a strong passion for. And I believe they mistakenly say that anterior is V1 through V4. They are mistaken. Okay? So just to save any arguments that may happen because, well, they're wrong. Mine is right, trust me. Take a look at your text. They'll tell you. Take a look at Egan. It'll tell you. Don't take a look at that other book. There's Mr. Einthoven. This is how he created this concept of doing an EKG. He put his arms and leg in electrolyte fluid to be able to measure the different things. And this was the EKG machine that... All right. Usually you could pick up when you put the leads on incorrectly, and these are 3 different clues that should point you in that direction. Lead 2 should always have an upright P. If the P wave is inverted, you got 2 leads backwards. lead 1 should have a negativity, and if you're seeing that, you know we got something wrong. And AVR should always be inverted. If you're seeing it upright, you got something wrong. Okay, so graphically, oh, here's a good one. Which lead should I suspect is not attached correctly? Which one do you see a nice tracing on? Where? Lead 3, right? So which two electrodes or two points are lead 3 looking at? Left shoulder and the leg, right? So which lead is probably not hooked up right? The right shoulder. Not lead. Which electrode? Lead 2, or the right shoulder is the one that we suspect. Because lead 3 is tracing pretty, the other two are ugly. So it's probably that right shoulder that is there. But here's this is out of your text, showing the lead misplacement. Again, if you're seeing upright in lead R, something AVR, something is definitely wrong. Inverted P wave lead 1. Lots of negativity in lead 3. You shouldn't see that. That should be a positive deflection. Remember last time we were talking? If the current is moving in the direction the lead looks, it's a positive deflection. If it's moving opposite, it's a negative deflection. That's why AVR is normally looking from the center of the chest to the right shoulder. That's opposite entirely of what you would normally see. So it's going to be an inverted P, predominantly a downward QRS complex and an inverted T. Clock. Can't you tell? Square root of 9 plus 9 minus 9. All right, let's move on then. Remember pictures March 21st, if you haven't remembered that already. This is for those of you who are on Facebook, and I know some of you are probably on it too much, but I think. Oh, that's right. They did end up changing. I'll have to change the link on there, but they end up. Let me see if I can find it here.
Who's that guy next to your picture?
Who's that guy next to my picture? That would be me. Stuff people post, you know. Jeez, got nothing else to do in your life. Ain't that the truth? Shoot, I can't find it here. All right, I'll email you the link, but it's a really good Facebook page because they post odd EKGs, odd 12 leads in a scenario, and they say, hey, what do you think is happening? Yeah, and there's a couple of links within there, one of which is he does a wonderful job talking about bundle branch blocks and axis deviation. So Facebook can be useful at some point. Let's see if this will run. Sometimes. Except when you're bitching about. Okay. Hold on a second. Come on. You just hate me, don't you?
Luckily, AOL Top Speed is the fastest way to surf the web of any national dial-up service.
Honey loves me, she be naked.
Mommy's home.
Okay. And crap is not one of the options, so don't choose that one.
What does that mean?
Explain.
That if you look at the electrical potential, there's an initial rapid rise in electrical change that occurs. It's because the rapid movement of sodium into the cell. Those are done through what are called fast channels. Then there's a maintenance, a plateau that exists because there's a continued influx of not only sodium, but now a slower influx of calcium. All the while, potassium is moving in the opposite direction, and you end up having that shift from being relatively positive extracellularly versus intracellularly, and that depolarization process is what ends up happening by those ions flowing through. Okay? Sodium is fast, calcium is slow. Nobody wants to play? Okay. Sure, lock up on me. Why not? This has just been a wonderful day.
Try being us. That was a deep little theory. Really had words.
Let's just go back to the video.
Never comes right. What was the answer?
What is the answer?
I don't know, I put one.
40 to 60. 60 to 100 for SA node. 40 to 60 for AV, less than 40.
Yeah. All right, good. At least I learned something, right?
Which artery supplies the right atrium and ventricle with blood? That's pretty much a done. When cannot depolarization happen? I sound like Yoda. Depolarization cannot occur. If you said absolute, you are correct. Okay. Absolute is the initial portion from the beginning of the QRS complex to about midway through the T wave. After that, it's a relative refractory period where you can have depolarization happening, but we don't want it to happen because the heart's in a fragile state at that point. What structure functions delay conduction of the ventricles? AV node. Whether it's the AV bundle, whatever, bundle of his, blah, 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 blah. I combine them together. So, which of the following can cause dysrhythmias? Enhanced automaticity, escape beats, conduction disturbances, and reentry. That's all of them. Yep. That is all of them. And we'll come back and visit those again when we talk about atrial tachycardias. Okay. ECG paper, as Mary probably covered with you, the key part is that each one of those little boxes is 0.04 seconds. So if you add 5 of them together, you end up with 0.2 seconds for one of the big boxes. And we're going to use that because we want to distinguish how wide certain aspects of the tracing is. So here we end up seeing, this is what is considered to be a millivolt. It's an electrical test that they end up doing. But here's your ECG tracing that you end up having as it sits there. So for each of these, we want to be able to determine rate, regularity, look at the P waves, PR interval, QRS complex, ST segments, blah, 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 blah. Reading an EKG is basically pattern recognition. In order to recognize patterns, you have to have some sort of a structured approach to how you're looking at them. This is one method that we can end up using. First of all, how do we determine the rate that a ECG is at? 3 different ways, each of them getting successively more exact. One is to take a look at the number of R waves in a 6-second strip and multiply that by 10. Okay. Secondly, we can count the number of large boxes between 2 QRS complexes and divide that number into 300. And third, we can look at the number of small boxes and divide that into 1,500. Whichever way you use, I don't care, as long as you get to the answer. So here's an example. Now this, you can't quite see it, but there's a little hash mark there, hash mark there, hash mark there. Each of those are 6 seconds. So, I'm sorry, 3 seconds. 2 of them are 6 seconds. So we count the number of QRS complexes between those two. 1, 2, 3, 4, 5, 6, almost 7, so the heart rate's probably something like almost 70. Okay. Using the other method, how many big boxes do we have between 2 complexes? 1, 2, 3, 4, 5. Divide that 5 into 300, we get 60. Ooh, I guess that 70 wasn't exactly correct. If I were to go even further, 5, 10, 15, 20, 25 into 1,500, I think that works out to 60 also. But you basically are able to determine it. So I would feel comfortable giving you a strip and saying, what's the rate? Easy, right? Okay. And there's all kind of ones that are out there, but we'll leave it go at that. So again, just some of the, you should know the individual waves that are present. P wave is the first positive deflection that you end up seeing, especially in lead 2, where you would primarily be looking at. By definition, the first downward deflection after the PR segment, and again, this is what is considered to be the PR segment here. The first downward deflection is the Q wave. So this portion right here is the Q wave. Not all ECG tracings will have a Q wave. The first positive deflection after the Q wave is the R wave. Okay? It's an individual wave in and of itself. The first negative deflection after the R wave is the S wave. So there are 3 separate things in this QRS complex. I'm being very precise for a reason, as we'll see. And then following that's T wave. A couple other things that are there: the PR interval from beginning of the P to the beginning of the QRS complex, ST segment, which is from the beginning of the from the end of the QRS complex to the beginning of the T wave, and a QT interval, which is basically again that portion from the beginning of the QRS complex to the end of the T. Hoggity, hoggity, hoggity. So let's take a look at the P wave and the PR interval. Again, here's my P wave, here's my PR interval. And P waves can look differently at different points in time. Normally it should be just nice rounded positive deflection. Sometimes there's a second impulse that's kind of in there and it's got a little notching to it. Sometimes they're tall and peaked, sometimes they're inverted. They're all P waves, but they're doing different, they're showing a different shape for a reason. There's something behind that reasoning. PR interval is normally 0.12 to 0.2 seconds. So 3 small boxes to 5 small boxes. And basically when you get longer than that process, there's something wrong with the delay. There's something where the AV node is delaying that longer than it should. Shorter than 0.12, you'll end up seeing where it's probably not a sinus beat. It's something that is closer to the to the AV node. So if I were to look at my thing, instead of it firing back here at the SA node down to the AV, It's something where it's much closer, so there's not as much of a duration for the PR interval. Still within the atria, but not from the SA node. QRS complex, again, we talked about there being multiple waves that are there. And yes, we can have things like R prime, S prime, Yahoo. We'll talk about that when we get into bundle branch blocks. Represents ventricular depolarization. The maximum is 0.1 seconds. If it's wider than that, then you end up, which is basically 2.5 boxes. If it's wider than that, then we have some other, we probably have either a bundle branch block or that origin is out of the ventricle. Okay, and we're going to find that long-term wise, the presence of a prominent Q wave indicates that in a specific lead indicates that there's a damage of that portion of the heart that is there. This is why I was being so precise as far as what we had. Is there a Q wave there? No, so it's an RS. Now notice the R is small, the S is big. Why? Because it's predominantly an S wave that we see there. So we call that a small r, big S. Here I have an RSR prime. Small R wave, first positive deflection, right? I then have an S wave. I have a second R wave now. The hell is that coming in there for? Well, as we'll find with bundle branch blocks, it goes down, makes a turn to come back, and then comes back down again. So it's basically an impulse that's going through the heart in a non-straight line, if you will. Okay.
So what, by looking at that one and then the one next to it?
Yes?
I mean, how would I determine that it would be a T wave? Because it's like,
Oh, no, this is still the QRS complex.
right, but like the little R on the end.
You won't have a T wave until you have an isoelectric line after it. You have to have that yeah, you got to come back to baseline before repolarization can happen. But again, the capital and the small have to do with the height of the individual waves. So, and the weird one is this one, where there really is not a Q, but they call it QS. I don't know why. Okay. That's the one that kind of doesn't fit any kind of pattern. It only has a negative deflection. And why it's there, we'll talk about another day. Then the ST segment, and this is basically from the QRS to the beginning of the T wave. It begins with what we call a J point. Don't you love all these letters? That's what it's for. No, it's not for Jesus. I kid. Sorry. And again, this is the repolarization process that ends up happening. Under normal conditions, that should be a flat line. So after my QRS complex, I'm going to have an isoelectric, meaning no charge one way or the other. If I see something where that is below baseline, we call that ST depression. If I see something where it's elevated, obviously that's ST elevation. And we're basically being able to tell at what point in that process of an evolving irritation to the MI before death we are at. Okay? So we look at this as far as where the ST, if it's elevated or depressed, one small box after the J point. So the J point is right there. I then look over one box and say, is that level? Is it elevated? Is it below? Let me give you an example. Here's my ST segment. Okay, here's my J point. One small box over. What do you think about the ST segment at that point? It's level, right? So there's no ST elevation or ST depression. Here's my J point, end of the QRS complex. One box over, is that above or below? It's above, so I have ST elevation. And finally, here's my J point. One box over, is it above or below? It's below, so I have ST depression. You need to understand, because that's how we're going to determine if there's some changes going on to the myocardial wall indicative of ischemia, infarction. I'm sorry, ischemia or injury. If it's infarction, it's a whole different story. Okay. So this is how we can tell when this process is evolving, by looking at ST segment deviations. The J point is the fancy name for the end of the QRS complex. Go one box to the right, and is that line now above or below the baseline? Normal would be it'd be nice electric. You could draw a straight line from the beginning of the, prior to the P right on through. So here's my J point, one box over. You can see some elevation there, and oh my, yes, there's some elevation. Elevation, okay. Can you all see the ST elevation? And these are obviously taken at different points in time, and you can see how we're starting to see this evolution, that the ST elevation is getting higher and higher and higher, and that's showing me that I have more and more ischemia going on. Okay? So in which leads do I see some ST elevation? 2. And immediately upon saying 2, what's the next one I should look at? No. 3. Why? Because changes that are happening in lead 2 probably will show up in lead 3 and lead AVF. Which way is lead 2 pointing? Down. Lead 3, down. AVF, down. Which wall is involved? Go back to the slide I said you need to pay attention to. 2, 3, and AVF is an inferior. And you can see the ST elevation in those 3 leads. Okay? So this is how, when I look at a 12 lead, I can tell where the origin of the MI is. I'm got a lot of blank faces looking back at me here. No? Okay. Yeah. Sure. Actually, there's a slide in there, I believe. Kind of like that, yeah. Something else to fail, I know.
You have really big hands.
So here you have a 12 lead EKG, and you can see 2, 3, and AVF all deal with the inferior wall. 1, L, 5, and 6 all deal with the lateral wall. 1 and 2, septal. 3 and 4, anterior. And this little box up here kind of sums it up. Okay? You need to know this.
Can you send it to us, please?
I believe I have. If I don't have one blown up in the back, yeah, fine. I'll do even better. I'll put it in Angel.
Thanks, dear.
Thank you, Val. All right. So again, you can expect on the exam I'm going to give you a 12 lead. You're going to need to identify where the problem is, and from that, I might say, oh, and by the way, which artery do you think is involved?
Then you can perform surgery after?
Got me? Okay, let's continue on then on our trip down the ECG tracing. T-wave is ventricular repolarization. We know that absolute is from the beginning to about the midway. After that is a relative refractory. It's normally oriented in the same direction as a QRS complex. And we're going to see an inversion with myocardial ischemia, and we're going to see some changes with an alteration in potassium level. Flat means hypokalemia. And you can see you can actually get it to the point where you end up having a depressed or inverted T wave in that case. When you're seeing a tall peaked T, you have a situation where you have a high potassium. So think of the level of potassium is how big the T wave becomes. If it's small and flat, it's a low. If it's tall, you end up having a big one. Okay? That's an important slide there. And again, this is maximum. A max of 0.1, a max of 0.2. All right, artifact is basically just where we got some garbage interfering with it. It can be caused by a lot of different problems. A couple of them that you do want to see is this, you want to be aware of is this situation, which is 60 cycle interference. Person is shaving, person is, while the EKG is going on, they're listening to their transistor radio. I don't know. There's some other kind of interference from something else. Okay? You end up seeing. And again, 60 cycle applies that it has to be plugged into an outlet. So why they have an electric razor in the IC and the CCU, who knows? But there you go. This is an artifact caused by either loose wires or a patient moving a lot. Remember my dad was in the CCU and he was sitting there going like this with his electrode, driving the nurses nuts. Show off like that. Muscle tremors or seizures, you can end up getting where you can't make out the baseline. So you want to be able to identify the different types of artifacts that are present and how we would go about correcting them. All right. Axis deviation. You remember back now.
I teach this a little bit different than Mary, so whichever way works for you is okay. But remember, there's identification. We can use bundle branches axis deviation to tell bundle branches, to tell hypertrophy, and to tell muscle damage. Okay, it's the general direction of current flow as polarization happens, and the normal axis deviation is in the 0 to 90 degrees range in the frontal plane. And what we're going to look for are two leads. Lead 1, lead F. This is the dumbed down method for being able to tell axis deviation. So I take a look and say, do we have a net positive or a net negative deflection? Can you all see that this is primarily a positive deflection? And this is primarily a negative deflection. And if I don't know, I count the boxes. This is from our isoelectric line here. This is 10 boxes down and 3 boxes up. So I'm saying it's predominantly negative. Okay? So then I look at lead 1. And I look at AVF, and I say, is it positive or is it negative? Well, if they're both positive, it means it's looking to the left and it's looking down. And that's the direction the current normally would move, isn't it? To the left and down. If I have it to the left,
but it's moving up. I have a negative deflection in AVF. It's not moving to the left and down, it's moving to the left and up. That's a left axis deviation. If I have a negative to the left, lead 1 is a negative deflection, but I have a positive deflection in AVF, it's moving to the right and down, well, that'd be a right axis deviation. And if I have them both being negative, this is what we call indeterminate or no man's land. Who the hell knows? Because that means the impulse is moving which direction? To the right and up.
Bleeding out, bleed out.
So this is kind of a picture that puts it in light. Let's look at this. Both positive? Yep. So that means that I'm in a normal axis deviation. 1 is up, meaning it's going to the left, but AVF is negative, so it's going down. It's going the opposite direction. It's not going down, it's going up. It's going in this direction. Left axis. Lead 1 is negative, meaning it's going to the right. F is positive. It's going down. Right axis deviation. It's a lot easier. Now, what it doesn't allow you to do is say the axis deviation is 92 degrees. Who cares? Okay. Normally, we're going from 0 to 90. Do I care if it's 102? No. There are other methods which will allow you to give you a precise axis deviation. I don't care. Are we dealing with the left, right, or normal? And if we got this, we got real problems. They call it here extreme right axis deviation. I like the term no man's land because that kind of just says, we don't know where the hell you're going. It's in the text. Yeah. So again, here's that slide a little bit bigger so you can end up seeing, just looking at 1 and F. I'm sorry? Might be. So again, then we're talking about why we have this happening. Normally, because the left ventricle is bigger, you're going to have that direction where it's in that 0 to 90 degree quadrant. It'll point towards hypertrophy and away from infarction. Because infarction means dead tissue, it can't go in that direction. So if I have a left axis deviation, that means my left ventricle is either larger than normal or I have a right ventricular infarct. If I have a right axis deviation, I either have an increase in the right ventricle, as you would see in cor pulmonale, or I have a left-sided MI. Okay? Yes?
Can't some axis deviation also happen if someone is anatomically or hurts?
Absolutely. Absolutely. Pregnancy,
Yeah.
morbid obesity, yeah.
What happens if they're both? A past MI and, right.
It probably, you know what it probably would do? It would neutralize itself and look normal. Yeah. No. Another way to look at it, if I have a positive deflection in lead 1, color off that side of the circle. If I have a positive deflection in AVF, color off the bottom of the circle. And what you're left with is the merging of the two. Another way to look at it. Okay. If I see crayons on the test, I'll definitely know. So again, to the left and down, both positive, normal axis deviation. To the left and up would be left axis. And again, that's where we might see some, as we said, anatomical things going on, where the diaphragm is pushing and the heart is being kicked up towards the left. Left ventricular hypertrophy, or a right-sided, or actually an inferior MI will yield the same exact picture. We didn't really talk about bundle branch blocks, but if I have a left anterior hemi block, you'll actually get that kind of a picture also. But we'll let that one go for now. Right ventricular hypertrophy, it's negative in lead 1, which means it's looking to the right. It's positive in AVF, means it's looking down, as you would expect it to. And this is where we end up seeing some right ventricular hypertrophy. If you had dextrocardia, this is where you would actually see that also, but that's kind of a thing. We talked about COPD and having the cor pulmonale. And a lateral MI on the left side of the heart, that wall is going to be pointing in, it's going to push it in the opposite direction. This one, you got a weird one. Okay. Usually, that's where you'll see that happening. And this makes logical sense. If I have a pacemaker, where's the impulse starting? It's starting in the ventricle. And it's moving upwards in the opposite direction from normal. Assuming you got the leads put on correctly. So that's an easy way to pick up axis deviation. Okay. Whichever way you want, the way Mary taught you, the way you want to use it here, that's fine. Well, the classic way that I think Egan does it, he says, look for the lead that has the most positive deflection and what's perpendicular. Oh, good God in heaven. This is a lot easier. Sure she did. So what do we got here, guys? Where's the axis deviation? Right? It's actually up and to the left. So that would be if I merge those two. Left axis deviation. Nope. I can draw really well, can't I? So it's going to the right, and it's going down. So that's... I'd feel comfortable giving you an EKG, a 12-lead picture, you telling me, maybe I would say, where's the is there any deviation present? Or I might say, which of the following conditions would show you this picture? And you would say, oh, right ventricular hypertrophy. One has a predominantly negative deflection. It's not inverted. Yeah, it's predominantly negative, though. What do you think? Left axis deviation. Positive, negative. Right? This is predominantly positive, this is predominantly negative. So it's going to the left and it's going up. Give me 10 more minutes. Are you done? All right, we'll stop there then.